In the calf, the muscles that normally strain are the muscles of the posterior calf. The muscles of the anterior calf, normally they are never got injured. So we have the gastrocnemius, medial and lateral, and soleus. I will include a comprehensive review of the anatomy, physiopathology, clinical findings, differential diagnosis, and imaging features of the lesions affecting the athlete with lower leg pain. The bone tissue dynamically remodels in response to mechanical stress. In case of submaximal strong and repetitive bone overload, with adequate recuperation, the tissue adapts to the load and can experience further loading without damage. If the mechanical stress doesn't stop, the microfracture may propagate and end up in microfracture. The presence of microfracture is considered to be a stress reaction of the bone. In case of macrofracture happen, in case of a macroscopic fracture line is seen on imaging, it's considered to be a stress fracture. Regarding the biomechanics, we also have to understand that bone stress injuries happen in specific areas of the bone. It doesn't appear anywhere. Normally, it affects the tension side, the maximum tension side of the loads, and the maximal compression side of the bone. How we can see fractures in imaging? So here we have some examples with the different techniques that we normally use. There is an incomplete fracture. It's a radiolucent line. The signs in X-rays correspond to the incomplete fracture. Normally, they are perpendicular to the direction of the load. In this CT scan, this is a coronal reconstruction, and we can see a fracture here. And we can also see some periosteal reaction. This hyperdensity adjacent to the fracture line, this is a periosteal reaction. This is also a radiological sign that can be seen sometimes in X-ray. In MRI, we can see here, this is a T2 coronal view. In this T2 coronal view, we can see some bone edema that correspond to microfracture, or to a stress reaction. Bone stress injury spectrum. Here, there is a classification that I personally use. There are many classifications of bone stress injuries. I use this one. Why? Because it's easy, is also quite spread use worldwide. I think it's one of the most common classification. I will show you the difference between bone scintigraphy and MRI. On the right, we see a bone scintigraphy image, and on the left, an MRI. So regarding the voxel size or the pixel size, you see in bone scintigraphy is less defined. You are not so specific. You see like a uptake in the bone scan, but sometimes it's very difficult to know if it's an inflammation or is bone tumor or there is a fracture, let's say. However, in MRI, we have much better resolution in detail, and we can assess much better. Plus, the MRI doesn't use radiation, and you don't need any injection. I just will mention a little bit about this new technology that this is called the dual energy CT. It's a subtype of CT scan that is able to detect the bone marrow edema. So potentially in some certain settings, in some departments, in some hospitals, may have a role, okay, in the future. They could detect grade 2 and grade 3 injuries. Regarding return to play, in this article published by Kajowski, he found that he found a correlation between grade 1 and grade 4B. Cases with grade 4B has 10 weeks, more or less, return to play. Grade 1, just 2 weeks. The other 2, 3, 4 A grades, they had like a 5 weeks of return to play. Time before, I remember when we saw one MRI with a lesion of the muscle of the calf, we just describe, okay, this lesion is in soleus, okay, this lesion is in gastrocnemius. However, we now don't do that anymore. We are more precise. We know the anatomy better of these muscles, and we know they have some implications or potential implication in the return to play. So I